thing about this is that these are really not single ventricle defects. I don't like that term particularly either. I certainly agree with that concept that these aren't single ventricles at all. There's more than one there in all of these. But what I mean by that is that these are defects in which a two-ventricle repair isn't achievable with an acceptable mortality and long-term outcome for one reason or another. And there are a number of reasons why that might be the case. And it isn't always because of size of the ventricle. Now, a couple of these that I want to show that we haven't talked about before today really are more or less single ventricles, some of them double inlets, particularly some forms of double inlet right ventricle where there really isn't an identifiable left ventricle. In most forms of double inlet left ventricle, the only thing else that's there is an infundibulum and not really another right ventricular sinus. But there are some hearts with straddling AV valves where it's difficult to achieve a two-ventricle repair for one reason or another. We already looked at extremely unbalanced AV canal defects, which is another group where it may be difficult to achieve a two-ventricle repair. Many patients with heterotaxy syndrome, because of the ventricular size or distribution and presence of a common AV canal defect and various and sundry other things, it may be difficult to achieve that. And Epstein's anomaly is another group. And then there are a group of very complex things, some supro-inferior ventricles, some things like that I'm not going to go into because they're really very uncommon types of abnormalities. But I do want to look at double inlet left ventricle and just look at the morphology of some of these. Here's an aorta. This is an L-loop double inlet left ventricle. The aorta is to the left, the pulmonary artery is over here to the right. And when we look in the right atrium, see the foramen ovale here, or the fossa, it's closed in this case. You can't get through there. This is the eustachian valve here. The inferior vena cava comes in on the other side of this eustachian valve. And you can see this is the right atrium. It's typical right atrial morphology with pectinate muscles extending out around the vestibule of its AV valve, which is right here. And the AV valve opens through this orifice here into a large ventricle that is left ventricular morphology. And the reason I say that is because it has the wall over here, the septal wall of the left ventricle that we consider part of the left ventricle, but really has the smooth base and a trabeculated apex. There are free wall papillary muscles over here. And you see this right AV valve, the right-sided AV valve is this one, attaches only to the free wall papillary muscles. It's far from the septum, and it looks a lot like a mitral valve. Two papillary muscles, two leaflets. Then if we go into the left atrium here, there's the left atrial appendage, and we'll look, here's the fossa. You can see there's a little hammock of septum primum there, but you can't get through it, it's closed. But there's a large AV valve out of here into this orifice, and we'll follow it through and see where it goes. And it goes through this other bigger AV valve over here. And it has a septal leaflet here. It has a superior anterior leaflet here. There's the septal leaflet. And it has an inferior leaflet here and a big anterior leaflet up here, more or less like a tricuspid valve. And it has multiple attachments onto the crest of the interventricular septum here. So this is a little more like a tricuspid valve. Sometimes this is the case. Sometimes the valves don't have much character to them at all. And there's pulmonary to AV valve continuity up here in the back. This is the ventricular septal defect or interventricular or ventricular outflow communication. And in this case, you can see that a little bit of this tricuspid valve or the left-sided AV valve straddles through the defect and into this tiny outlet chamber up here that supports the aortic valve. And here we see a trileaflet aortic valve, coronary artery orifice there. That's the left-sided coronary. We have an aortic arch coming off of this with no particular arch obstruction.
Here's the pulmonary valve. Down here you can see the leaflets of the valve in the root. So this is a big ventricular chamber. And there you can see the outflow to the pulmonary artery there. And notice there's this excrescence. There's muscle here underneath it, but there's also this excrescence of AV valve tissue that protrudes into the outflow tract and can cause obstruction. Sometimes you can see obstructing structures like this from the adjacent AV valves. And in this case, the pulmonary root, which is the posterior root, is between the two AV valves, which is quite typical. You can see that this ventricle is quite hypertrophied and is a large ventricle because it's doing systemic and pulmonary work. But this is a fairly typical morphology of a double inlet left ventricle. Now let's contrast that with a double inlet right ventricle here. Here you can see the aorta over here, pulmonary artery here. Here you see coronaries coming down from the aorta. And if we look in the right atrium here, there is a patent foramen here in the fossa area. This is a morphologically right atrium. You can see the typical pectinate muscle and also the coronary sinus there. And here's the AV valve coming out of this. Here's the other atrium, the left atrium, with septum primum on its septal surface there. It's a smooth atrium, typical pulmonary veins coming into it. Small appendage up here, so it's typical of a left atrium. And it has an AV valve. There's the appendage. And it has an AV valve coming out of it, also going into this big ventricle. Now we'll open the ventricle here, and you can see somebody's put a device in it, and we'll talk about that in a minute. But here's a right AV valve and a left AV valve. They don't really have much character to them. They sort of look like AV valves. But notice that there's this big posteromedian ridge here in the middle of this big right ventricle. There's no wall here that looks like the left ventricular wall. It's just a very heavily trabeculated right ventricle. And this ridge is typically between the two AV valves, and it can look like, in some cases, an interventricular septum. Now we're looking up at the outflow. That's the outflow septum, or the infundibular septum there. And on one side is the pulmonary artery. On the other side is the aorta. As you might expect, there's no separate chamber that leads to either of these great arteries. They come directly out of this big ventricular chamber. Now notice we're putting the probe behind this posteromedian ridge to indicate that it doesn't attach along its length to the posterior wall, which is a characteristic of it being a posteromedian ridge. Here's the pulmonary artery here. Sorry, that's the aorta. Yeah, that's the right-sided one. That's the aorta. There you can see there is an aortic narrowing at that point, and you can see how narrow the subaortic area was in this patient. Here's the pulmonary artery, and there's a ductus right here that leads up, or did lead up. It's now closed. There are the two branch pulmonary arteries. That's a ligament now. We'll see that it's closed. There you can see the little dimple here where the ductus ligament used to be. But there is a bit of aortic narrowing up at this point. But let me go back and just mention briefly the device that was back there. We'll see it in the ventricle here. Yeah, there we go. There it is. We'll just let it sit there. So one of the risks of this kind of ventricle with this huge posteromedian ridge in the back is to confuse it as being actually two ventricles. The way to avoid that is that there really isn't the wall in this ventricle that looks like the left ventricular septal surface. So it's very hard to imagine thinking that it really is two ventricles, but clearly somebody did, and they tried to close a ventricular septal defect with this device. So it's not that hard to make that kind of mistake if you're not careful and don't really think about the morphology of the ventricles and think about that if there are two ventricles there, one of them should be left and one of them should be right. They aren't like the atria that can look like each other. They really don't do that. They develop from a different part of the heart tube that really isn't bilaterally symmetrical or can't really be bilaterally symmetrical. And so there should be one of each, and if it just looks like a big amorphous chamber with lots of big muscle bundles in it, it's probably just a big right ventricle, even if it has this big ridge in the back between the two AV valves that could look like a septum. And the other key to that is, as you can see, the probe easily goes behind this and goes up and down, and that indicates that it's not connected to the wall along its length like an interventricular septum typically is. So here's another kind of ventricle that might not be appropriate for a two-ventricle repair. This is a straddling mitral valve. We saw the left ventricle. Here's the mitral valve straddling through this anterior outlet type of defect into the infundibulum over here, and you can see there's a papillary muscle that receives attachments of the mitral valve. Now we're looking into the right ventricle over here. Here's the straddling part of the mitral valve right there up into the infundibulum. Here's the tricuspid valve, the mitral valve. This is a double outlet right ventricle, which these almost always are. Here's the ventricular septal defect, and there again is the straddling part of the mitral valve. Very often the mitral valve is small when it straddles, and it may be too small to be useful. The tricuspid valve is seen over here. Here, the two great arteries are up here. So this is another type of heart. There's the straddling part of the mitral valve up into the infundibulum. So this is another type of heart that might not be suitable. And this is a heterotaxy syndrome. This is a double outlet right ventricle. Here's the pulmonary artery. The aorta is over here. And this has the right-sided atrium has typical right atrial pectinate muscle morphology to it here. There's a big interatrial communication. There you can see the inside of this atrium. And here's the interatrial communication, the AV valves down there. Here's the edge of the septum right there. And if we go to the other side, we'll see that there's a superior vena cava over here that comes into the other side of the atrium, into the left side right there with an azygous vein coming into it. All of that stuff right there. I think my cameraman was having a little trouble this day. So here's the inside of that. The inferior vena cava also comes into this side of the atrium. But once we'll look down at the atria are very complicated, very confusing. And then when you get down to the ventricles, we'll see that there is a common AV canal, double outlet right ventricle, and other things. There you can see again the edge of the septum leading down into the AV canal defect. So the upper part of the atrial septum is intact. It's just the AV canal defect here. And here you can see that this is sort of indeterminate atrial morphology. There's some pectinate muscles, but not much. Here's one of the semilunar valves, the aorta. Here's the pulmonary artery on the other side, which is small. There's pulmonary stenosis, as there often is in many patients with heterotaxy syndrome. Here you can see this fibrosis in the outflow tract, which is fairly typical for patients who have a high velocity jet going through a stenotic area. And there's the pulmonary valve, pulmonary trunk out here, which is reasonable size. So from that point of view, it certainly would seem possible. Here's the right ventricle here. Again, the infundibular septum with pulmonary valve above. And here's a common AV valve, which is some of it into this ventricle, although we'll see most of it is into the left ventricle, which is a little unusual for this kind of heterotaxy. But some of the AV valve is here, but most of it is here over this left ventricle. There's a huge ventricular septal defect. So you could say, well, maybe it's possible to tunnel this into one of the great arteries or the other. The aorta is pretty far away. The pulmonary artery is closest to this, but there's severe sub and valvar pulmonary stenosis, so it gets a little more difficult to get from here over to the aorta. The posterior leaflet here is not very good. This valve was probably rather regurgitant. So all in all, this is the kind of heart where, again, it's very difficult to think about doing a two-ventricle repair, but it's just as bad to think about doing a single ventricle repair in somebody like this, because the outcome may not be very well with that kind of approach either. So those are some thoughts, some hearts for your consideration of things that aren't really single ventricles, but we often manage that way. And some hearts that it's sort of hard to know what to do with in any case. Here, sir. Sir, here's your microphone. Here's the microphone. No, I
I had realized that when they were talking, when the topics for single ventricle were included, there was no discussion of tricuspid atresia. And as I've mentioned, I believe you should really not talk about single ventricle, but talk about the specific lesions. So I'm going to talk a little bit about tricuspid atresia.
I hope I'm having a little problem here. I think I'll have to just do it this way.
There we go. So, as I said, I think you should talk about the specific lesions because they're all different in the way in which you handle them, and they can't be classified as a single lesion. Now, tricuspid atresia can present either with normal aortopulmonary relationships, and they may have an intact ventricular septum. That's not common, or they may have ventricular septal defect. And the other complex that needs to be discussed is tricuspid atresia with aortopulmonary transposition. Now, obviously with complete obstruction, we don't have a pointer, with complete obstruction into the right ventricle, all the blood from the venous system has to drain. Oh, there, thank you. Has to drain into the right ventricle and all the, it has to pass through the foramina veli and go into the left ventricle, and it's joined in the left atrium by blood from the pulmonary circulation. And in the fetus, again, there's total admixture, as we've talked about with other lesions, and the saturation of the blood going to all parts of the body is about 55%. And again, the pulmonary circulation gets blood with a somewhat higher saturation, and the systemic circulation, the aorta, the ascending aorta, gets blood with a somewhat lower saturation than normal, the descending aorta blood with a somewhat higher saturation than normal. Now, when you think about this condition, normally about 20% of combined ventricular output goes across the foramen ovale. In this condition, everything except pulmonary circulation has to go through the foramen ovale, and that's about 70 to up to 80% of combined ventricular output. So the foramen ovale in this condition has to be big. Now, as I said, it's not common to have tricuspid atresia without a VSD, but there are some babies that present and fetuses that do not have a VSD, and in that circumstance, during fetal life, in order to provide blood output, all the blood enters the left ventricle and is all ejected by the left ventricle into the aorta. So that in that circumstance, the ascending aorta is large, as it is with pulmonary atresia, and the isthmus is wide. And blood flow to the pulmonary circulation is derived by left to right flow through the ductus arteriosus. Now, the blood going through the ductus is only about 20-25% of combined ventricular output, because that's what pulmonary blood flow is like, and that's considerably lower, so the ductus is small, and the ductus always arises with an acute inferior angle. Now, when there's a VSD present, it depends on what the size of the VSD is like as to what the circulatory pattern is. When there's a large ventricular septal defect, then even though there's no blood coming into the right ventricle through the tricuspid valve, a substantial proportion of blood can go through the ventricular septal defect into the pulmonary circulation, and it depends on how much blood is going through the ventricular septal defect. If it's large, then you may have a situation where there's enough blood being ejected through the ventricular septal defect into the pulmonary artery, that blood may actually flow from the pulmonary artery through the ductus into the descending aorta. If the amount of blood passing through the ventricular septal defect is smaller, then you may have to provide pulmonary blood flow partly through the ventricular septal defect and partly through the ductus arteriosus. So it depends on the size of the ventricular septal defect as to what the patterns of flow are like. Now, when you have the condition of aortopulmonary transposition with tricuspid atresia, this is a very interesting lesion, because there's almost always a ventricular septal defect in this condition, but the ventricular septal defect again varies in size. And it very much determines what is going to be the size of the ascending aorta and the isthmus. So that if there's a small ventricular septal defect, then flow into the ascending aorta is going to be relatively small, and blood will be provided through the ductus arteriosus from the left ventricle, so that the pulmonary artery arises from the left ventricle in this condition, and blood to the lower body is derived through the ductus. And depending on the size of the ventricular septal defect, the blood to the ascending aorta may be provided either through the VSD or otherwise retrograde from the... Now, another important point about this condition is that here you again see the circumstance where there's low flow into the ascending aorta and across the isthmus, and very high flow through the ductus arteriosus. Because of this, again, coarctation is going to be very common, and these babies have a very high incidence of coarctation. At least 50% of them have a coarctation, and perhaps more. And the presence of the coarctation is going to depend, again, on what the size of the ventricular septal defect is, because that will determine how much blood goes into the ascending aorta versus the through the ductus. Sorry. Now, after birth, the same applies to the role of the ventricular septal defect. If you have tricuspid atresia with a ventricular septal defect, again, all the systemic venous blood traverses the foramen ovale, and there's complete admixture in the left atrium and left ventricle, and again, the determination of arterial oxygen saturation is going to be determined by the ratio of pulmonary to systemic blood flow, just like in all the other complete admixture lesions. So that the final saturation will be determined by the magnitude of pulmonary blood flow, essentially. And so that if there's a small ventricular septal defect, there'll be little flow provided to the pulmonary circulation through the ventricular septal defect. Immediately after birth, there will be enough flow from the ductus arteriosus to provide an adequate pulmonary blood flow, so that oxygen saturation may be relatively good for a few days until the ductus closes, and in that situation, of course, there will be marked cyanosis. If the ventricular septal defect is of reasonable size, there will be a reasonably good flow from the left ventricle to the right ventricle into the pulmonary circulation. And in this circumstance, the clinical picture varies tremendously, because if there's a reasonably good pulmonary blood flow, these babies may not be very cyanotic. Now, in the immediate postnatal period, while pulmonary vascular resistance is still relatively high, they will not develop a big pulmonary blood flow, and they'll be reasonably blue. But as soon as pulmonary vascular resistance falls, the pulmonary blood flow increases, the degree of cyanosis improves. Now, when the ventricular septal defect is reasonably large, there may be a huge pulmonary blood flow, and we have seen some of these babies with tricuspid atresia with ventricular septal defect who develop such a large flow through the ventricular septal defect as pulmonary vascular resistance fall that they develop cardiac failure and present as ventricular septal defect with failure. And many of these babies in the past, before the use of ultrasound to diagnose the condition, were diagnosed just as ventricular septal defect without tricuspid atresia. Now, what happens though in these babies, there's a tendency for the ventricular septal defect to close, or become smaller, and as that happens, clinically they show improvement of cardiac failure, and then eventually they get severe cyanosis again. So what happens to ventricular septal defect is very important in these patients. Now, when you have tricuspid atresia with transposition, again, what happens to these babies after birth is going to depend on the size of the ventricular septal defect. If they have a reasonably good size ventricular septal defect, they will have reasonably good flow into the ascending aorta from the left ventricle through the VSD. If they don't, then they will have poor ascending aortic flow, and they have to provide flow through the ductus arteriosus. So that the ductus arteriosus becomes crucial if there's a small ventricular septal defect or a moderate-sized ventricular defect in providing flow, particularly to the lower body, but sometimes also to the upper body. So that if once the ductus constricts, they develop poor systemic output and become severely hypoxemic, severely acidemic. So that's enough.
Okay. I've prepared two talks for you. They're both on the website. One is a combination view of functionally single ventricles, and one is just a simple talk on functionally single ventricles. So if you've got an idle moment, you might want to look at both. Otherwise, you could just check it out with your local psychiatrist. I'm hoping to open this program, which crashed on me during the last go round. There we go. Works. Okay, well, once, again, the ultrasound goals are directed towards finding out all of the morphology so that a decision about the appropriate care can be managed with clinical and other input. So we have to look at the situs, obviously, because heterotaxy is a substantial risk for some of these diseases, and also define the pulmonary and systemic venous connections carefully, define the mode of the atrioventricular connection to the underlying ventricular mass, determine the AV valve morphology and function, assess morphology and function of both the ventricles, determine the position of accessory chambers or ventricles, whatever you want to call them, the size of the interventricular communication, and identify obstruction within the outlet chamber, display the great vessel position and the ventricular arterial connections, and finally assess size and distribution of the great vessels and associated anomalies. So basically, we'll start off with double inlet ventricle, which Bob Anderson called a double inlet atrioventricular connection, and vulgarized it to double inlet ventricle. So here we go. And we look here at a ventricle from the subcostal view of a left ventricular type of morphology, and you can assume that's a left ventricle because there's an anterior and here leftward associated outlet chamber. And if you follow the looping, this is probably from primitive right ventricle and this a primitive left ventricle. And here's the inlet into the AV valve. We can see the aortic arch, which is extremely leftward, and the origin of the pulmonary bifurcation. And when we look here in a closer look, you can see very nicely the pulmonary bifurcation as well as what appears to be a arterial duct here, where I've cited the origin of the left pulmonary artery. And we can look at this in the contra-orthogonal plane, and you see here the pulmonary artery posteriorly and the aorta anteriorly in this condition. And when we go into cross-sectional view, you can see that the aorta is anterior and leftward, the pulmonary artery posterior and rightward, and that you can see the position of the atrial septum as well. Now, one of the issues that we get involved in is, here is an example of double inlet ventricle. This is merely a reference to the underlying echocardiograms showing in the back here. But you see here where this so-called bulboventricular foramen is situated. If you follow the AV valves up, the posterior great vessel is usually wedged between the two AV valves, and here it is demonstrating subpulmonary narrowing, and here is the open bulboventricular foramen from which the aorta arises anteriorly. So we look at this and we can see these features here, and we look at the small bulboventricular foramen, which both Stephen Sanders and I have looked at as a risk factor for development of aortic arch anomalies. And I think you can see here is the aorta, here is the pulmonary artery. There's a lot more flow going into the aorta than the pulmonary artery. And the adage in double inlet ventricle is that the amount of flow balance is never right. It's either like the two sizes of trousers in the operating room, you know, too big and too small. And so there's either too much or too little pulmonary blood flow in some of these patients. And here you can see a very large pulmonary artery and a very restrictive ascending aorta with almost a hypoplastic ascending aorta arising off it. When we look at the inlets, I've opened this heart from the apex, and you can see the two atrioventricular valves. There's no real ventricular septum in either of these specimens. And when we look here, we can look at the AV valves in an apical four-chamber view. And again, you can see the two AV valves. The left AV valve is leaking. The right AV valve has a small degree of leak. And when you scan anteriorly, you can see in this heart that the first vessel to fill, coming wedged, as it were, just anteriorly between the two AV valves, is the pulmonary artery with the left and right pulmonary artery flow shown here. Now, tricuspid atresia. In tricuspid atresia, the vessels are either normally related or transposed in one or other fashion. In this example over here, we have an outlet chamber or a small right ventricle, a small ventricular septal defect, a little aorta here, and a big pulmonary artery here, and with a moderate-sized ventricular septal defect. Here is the more conventional form of tricuspid atresia, sliced in an echocardiographic cut. This one from the Mayo Clinic, this one from Professor Robert Anderson, and you can see here the absence of the connection or between the right atrium and the underlying ventricular mass in both of these examples here. And here you see this sulcus tissue, as I like to call it here, with the VSD. And one of the caveats that I have about VSDs, again, is they only ideal or big in a small period of time, and many times with the typical type of tricuspid atresia with normally related great vessels, one is astounded, again using Dr. Rudolph's adage that VSDs tend to close, at the rapid closure or restriction in the size of the ventricular communication. So clinically, you have to be very vigilant about watching these patients and not be cavalier about assuming that they will go on without substantial cyanosis for a long period of time. Okay, and here the other thing that you can get with functionally single ventricles is that although there are two AV valves sometimes in these patients, they are frequently not of the same size. So you may have one big valve and one small valve. And here is a double inlet into a ventricle. The outlet chamber is over here on the right side. This is the pulmonary artery. And you see the right AV valve is substantially smaller than the left AV valve. Sometimes it's not possible to see the second valve. You have to use multiple planes. The valve may straddle into the outlet chamber. And here you can see into the inlet chamber. Here is a straddling tricuspid valve. This is the mitral valve, and the valve is straddling across the ventricular septal defect and into this morphologically left ventricle. The right ventricle is rather hyperplastic, and the aorta is arising from it. The pulmonary artery is arising from the morphologically left ventricle. And looking at this example over here, you can see the hypoplastic right ventricle from which the aorta is arising. You can just see the pulmonary artery here between the two AV valves and the straddle of this tricuspid valve into the morphologically left ventricle. And I know Dr. Sanders would want me to say for you that in terms of straddling AV valves, that tricuspid valves usually straddle through a posterior ventricular septal defect, and mitral valves usually straddle through anterior ventricular septal defects. Now, another thing that would confound and upset you about AV valves is that even though univentricular atrioventricular connections or double inlet, although the valves may look perfectly good, the vessels are not. And here's an example of transposition with pulmonary stenosis. The pulmonary stenosis may be valvar in origin, as it is seen here and there, with a fusion of the the right and left facing sinus cusps, or it may be infundibular and valvar. As you see over here, there's a long sleeve of tissue. This is front, back, top, and bottom. You see the aorta in the front, the pulmonary artery behind, a smallish pulmonary valve with a long sleeve of tissue here. This is almost impossible to relieve surgically. And let's just put the last one into play. And you can see this marked narrowing with the tortuous direction of flow underneath the pulmonary valve related to subvalvular pulmonary musculature and fibrous tissue. And that can be very, very difficult to relieve. Now, not only in this univentricular atrioventricular connection may you have two valves, but one of the two valves may also be absent. And here is an example of an absence of the left connection to the underlying ventricle. The outlet chamber is anterior and superior in this four-chamber view. Here we are looking at it in a more subcostal view, and there's obviously an atrial left to right shunt here. No connection between the left atrium and the underlying ventricular mass, which is of left ventricular morphology, and minor AV valve regurgitation. Now here's an example of a straddling mitral valve. You see the mitral valve is fairly attached in the left ventricle. Here's the crest of the septum, and then tendinous caudal attachment into this anterior right ventricle here. I have several planes of tissue to show you that here. Here's the mitral valve clearly attached within the left ventricle and straddling through the AV, the ventricular septal defect into the other ventricle. Okay, and the left ventricle doesn't appear to be a very large chamber either in some of the cross-sectional views of looking at it. So that certainly determines the fact that this is going to require a single ventricle type of repair or Fontan procedure. Sorry. Here, once again, I've shown you that patient who has a small pulmonary valve and this bulboventricular foramen which has been stretched open, which is small here, and you can see a very small connection here. So there's also obstruction from the into the pulmonary chamber and also into the aorta as well. Here you see this long sleeve of tissue in this subcostal coronal view showing the deviation of the muscular tissue underneath the pulmonary valve, narrowing the left ventricular outflow tract, and some straddling of the AV valve across into the other ventricle. And here, once again, confounded by the fact, whatever the ventricular morphology is, here is a patient in whom there is double outlet from an outlet chamber. There's no AV valve going into this chamber. It's an anterior and rightward chamber from which the aorta and the pulmonary artery arise, ventricular septal defect over here, and a left ventricle left ventricular morphology here. So double outlet from an outlet chamber. And this is the work that we had published at the same time that Steve Sanders had published, that looked at the size of the interventricular foramen related to aortic arch anomaly, and obviously the smaller this area is, and 2 centimeters squared per meter squared in terms of the diameter was a critical factor for the presence of aortic arch anomalies. Now, Holmes's heart is described as a double inlet left ventricle with with the aorta rising from the morphologically left ventricle and the pulmonary artery from the morphologically right ventricle. And in case you haven't seen it, here is actually a picture of the heart described by Dr. Holmes, which exists in the pathological collection of Montreal Children's Hospital. And you can see double inlet here. The aorta is arising from this chamber and the pulmonary artery from the outlet chamber. Here is a double inlet with the aorta arising from the inlet chamber, which you can't see, but the pulmonary artery clearly arising from this outlet chamber. And you can just see the rim of the tricuspid valve through this very large ventricular septal defect. And we can see this echocardiographically as well. Here is the right AV valve. Here is the left AV valve, and wedged between it is the aorta with the arch, as well as the coronary arteries coming off in that order, coronary arteries and then arch. And so the aorta is arising from that morphological chamber, and the pulmonary artery is arising, if we look at the orthogonal plane, anteriorly from the right ventricle. There's the aorta posteriorly and the pulmonary artery anteriorly. So this is double inlet ventricle, or the Holmes type of heart. Now, we must always be cognizant, as Dr. Sanders had mentioned to us, the question of situs and malposition. Here's a patient with the trabeculations of the atrium surrounding a common atrioventricular valve, which was replaced in this patient. So double right atrial appendages, or right atrial isomerism, with a complete AV septal defect and a solitary AV valve. And here is another example of obviously an ostium primum component of a complete AV canal with a solitary type C valve straddling across the ventricle. As terms of AV septal defects, if the one or other ventricle, as you see here, a hyperplastic left ventricle, or in this case, a hyperplastic right ventricle with an AV canal straddling across the VSD into the ventricle of left ventricular morphology, these patients are candidates for single ventricle repair. And even patients that have, as we see here, with very large ventricular septal defect, sorry, my fault for hitting this, may be candidates for a single ventricle repair, when one has to consider that in septating this type of ventricle, we're going to have no function in this ventricle at all. So certainly there's additional subpulmonary stenosis as well, which motivated different attack than considering a two-ventricle repair in this patient as well. Straddling valves in transposition. You see here the valve straddling, a small hyperplastic valve straddling from a morphologically right ventricle into a morphologically left ventricle. And here you see the straddle once again, the valve in here with the aorta rising anteriorly from this ventricle. So I'm going to stop right here because time is moving on, and I'd like to follow Dr. Rudolph's good lead and say thank you very much for today, and let our other speakers carry on talking about the function. Thank you.
Okay, so we're going to talk a bit about function in the functionally univentricular heart, although there's always more than one ventricle, as was said. And I think as this is a slide from Mark Wielich that shows that the loading conditions of these ventricles, according to our palliative procedures, swing quite dramatically, certainly in the first few years of life, depending on the approach taken, and that's going to affect function and our assessment of function. Now, I want to just use this lecture to talk a little bit about the Fontan and about ventricular vascular coupling, and this reminds me of a remark Dr. Petropoulos talked to me about in the break, that in coarctation we talked about blood pressures and about ventricular vascular coupling, but perhaps didn't emphasize enough endothelial dysfunction. In fact, Dr. Sanders and I had discussions that part of the abnormalities in coarctation that I said relate to vascular function probably relate to endothelial dysfunction as well. So I want to complete that and talk about ventricular vascular coupling in the Fontan. Now, just to introduce the concept, we've talked about pressure-volume loops, and we've talked about this relationship, which is the end systolic pressure-volume relationship and the slope of that relationship in a family of pressure-volume loops under varying loading conditions. And we said that this is the end systolic elastance, which is a measure of contractility. If you take a line between the end diastolic point and the end systolic point and you draw a slope over there, you get the effective arterial elastance. And the point at which these lines intersect represents the ventricular vascular coupling. So the ventricle doesn't act in a vacuum. It ejects blood into a vascular tree, and this reflects a part of, I guess, the ventricular vascular impedance coupling. Now, in Fontan's, some authors had showed, in fact, that the arterial elastance is shifted, is steeper than usual, and the Fontans here are the solid lines. And I want to, in the next few slides, talk about this study from Senzaki, which really is a beautiful study in the function of Fontan patients. And he used invasively measured pressures with conductance, or with rather pressure-tipped Millar catheters, as well as echo to get surrogates of volume. The volume wasn't measured invasively. And what he showed that the Fontan patients have decreased cardiac index. But the question really answered in this paper, and that I want to put forward, is why do they have decreased cardiac index? Well, first of all, they have increased central venous pressures. That's not surprising. And they have increased arterial elastance. If you look at the end systolic elastance, this is invasively measured, there's not much difference. On the other hand, if you continue to look at diastolic function, using both invasive and echo measures of tau, which is just, I won't go into details, but this is a measure of how fast the ventricle relaxes and is considered a gold standard measurement of ventricular relaxation, or the peak filling rate corrected for a surrogate of volume. These were abnormal in the Fontan patients. And perhaps most importantly, this relationship between the end systolic ventricular elastance and the arterial elastance was quite abnormal in the Fontans. So from this work, he concluded that it's not a matter of contractility that's the problem, but rather a matter of the ventricular vascular coupling and perhaps diastolic abnormalities that then determine your cardiac index. And so these pressure volume loops, or pressure area loops as a surrogate in this study, kind of show what I showed you before. If you look at the slope of this end systolic pressure volume relationship in the Fontans, they're not that different from controls. I showed you the numbers before, but if you look at the arterial elastance, that slope is shifted upwards, and this point, the cut between them, is shifted rightward in the Fontan patient. So they have abnormal ventricular vascular coupling. He also found that they have abnormal systolic reserve, and both in the they aren't able to increase their contractility in relation to heart rate as much as the controls, and they also have the DPDT corrected for volume is abnormal, and they certainly have both abnormal diastolic function at rest, as I said beforehand, but also in relationship to exercise. The relation is the same, but at all points the tau is increased, meaning they relax slower. So that becomes important at higher heart rates where you actually want to fill more rapidly to account for the increased exercise and increased cardiac index. So if we just summarize those findings, just a summary of what I've already said, there's an increased afterload, a decreased cardiac index due to this mismatch. At baseline, you have abnormalities of cardiac function, but the decreased cardiac index is really due to the afterload. There's a limited inotropic response, and you have diastolic abnormalities that become perhaps most important during exercise, and you have a limited preload reserve rather than a limited contractile reserve, even though I think his data showed a limited contractile reserve as well. So I'm going to leave that study now and then go on to talk about a bit about myocardial performance. And Bob Anderson's group has shown how fiber orientation may be different in single ventricles and in tricuspid atresia specifically from normal ventricles. And the absence of a counterpart, of a normally sized counterpart in the ventricular interactions might therefore affect mechanics, both in terms of fiber orientation and in terms of having a second ventricle. And Mark Fogle showed by MRI how the absence of a right ventricle in tricuspid atresia causes abnormalities in left ventricular torsional mechanics. And that may affect systolic and diastolic function. In terms of regular echo measures, some people have asked, well, does the fact that you have a morphologic left ventricle matter versus a morphologic right ventricle? And there are quite a few studies on this. I'm not going to go into detail the conflicting results, but certainly in terms of regular echo indices and mass volume ratio, here's the morphologic left ventricle, right ventricle, and the mixed ventricles, or where they weren't able to determine the morphology. And you can see that the distribution of abnormalities looks pretty similar across the board. Now, in terms of deformation imaging, one should ask, can we reliably measure deformation in these single left ventricles? I can already hear some people asking, can we reliably measure this in any ventricle? And that certainly is an issue which I touched on in the first talk. Gautam Singh from Missouri, from St. Louis, Missouri, looked at this, and you can see that the parameters or the values obtained by echo speckle tracking are quite comparable to MRI with good correlation. But when you assess this with Bland-Altman plots, you can see that global function is not bad, and basal function certainly is good for longitudinal strain. In circumferential strain, there's more scatter, and you've got to be maybe more careful of the data. Nonetheless, longitudinal strain certainly seems that you can reliably measure that, and you get pretty good values versus MRI. Nasser Moiduddin, who was a fellow with us, but then when he went back to Ohio, looked at strain values in a small number of patients with a single left ventricle, predominantly tricuspid atresia, and you have in your handout, you'll have the characteristics there, and found reduced values versus normal controls, mildly reduced. He also looked at single RVs, and these were quite significantly reduced versus a subpulmonary control RV, but also versus a control LV. And so these ventricles have reduced strain. I think the question of what does that mean is still relevant because we don't know what that means. So if you see a patient doing relatively well and you see some reduced strain, what do you do about it? That is a question that is unanswered and needs to be taken in the clinical context. I think most importantly, maybe you follow them. Michael Chung looked at force frequency relationships in the univentricular heart. This is similar to the Senzaki data, and found that overall they do have contractile reserve, although it's a bit reduced both in the left and in the right ventricles versus normal. But overall, this supports, using isovolemic acceleration and the force frequency relationship, supports that these patients, their main problems are not systolic contractile abnormalities. The survival is pretty good, at least in the French data. And I just wanted to bring as my last slide this data from the Pediatric Heart Network and Brian McCrindle, who showed that laboratory measures of exercise capacity and echoes are pretty weakly correlated with overall how these patients feel and do after the Fontan. So I don't think echo and echo measures of function are everything in this population, but are just part of their assessment. Thank you. This was just to, I just forgot about this. This is to show a single left ventricle bivector velocity imaging. The echo report showed a reasonable function. That stopped playing. And there's not bad strain curves. They're mildly reduced. You can't see the numbers here, but this is at around -14, -13, but a pretty synchronous contraction and very different from what I showed you before in hypoplastic left heart syndrome and the RV. Thank you very much. No, it's not actually. No. Yes, but it was labeled as Munich when I looked on Google. But I was wondering where, but I hadn't been to Munich that extensively. Okay, so is that Norway?
Yeah, it's even like
It didn't look Munich. It's not from the States here either.
I apologize for being last. I feel like I'm always the one keeping everyone away from their beer or their nap. But I do think that this lecture has some beautiful images, so I think hopefully you will appreciate it. I really wanted to talk about, rather than just a single ventricle specifically, the Fontan in cardiac MRI, because I think that's an important, as you saw both from Dr. Friedberg's lectures, that MRI is used often with these patients to try and figure out the volumetric measurements. But this first image that I'm showing you, you can see is a 4D flow. I showed you this also with the scimitar syndrome yesterday, if you see. This is a double outlet right ventricle after Fontan. And you can see that the flow is showing you the flow from the IVC, SVC, as well as the flow down out the aorta and down the descending aorta. And I think if you watch it long enough, you really start to notice the different turbulences that occur in different locations. And you can see the IVC has quite a bit of turbulence right down here. Excuse me, the descending aorta, the IVC right over here, turbulence into the Fontan circuits. And then you see the turbulence in the right atrium that comes from the pulmonary veins. And I'll show that again. But the four things that you've sort of heard me time and time again say really characterize the Fontan: the anatomy, the flow analysis that I showed you. You can do several different analyses to show how much blood is going to each lung. The volumetric analysis that we've talked about with the volumes of the heart's ejection fraction, myocardial mass, and then the tissue characterization of myocardial fibrosis. And I'm actually going to talk to you guys about these in the opposite order. The presence of the myocardial fibrosis, you've seen me show time and time again in different anatomies and how it's playing a role. We showed it yesterday in tetralogy of Fallot. We know very clearly that it's a role in myocardial infarction, and tomorrow we'll talk about it in different cardiomyopathies, including hypertrophic myocarditis and ARVD. As I said before, it's unique to cardiac MRI, and I'm going to show you this image that I showed yesterday. This is a myocardial infarction. The histopathology is on the left, the MRI is on the right, and you can see here, even in the magnified location, here's the fibrosis, and even the branches and pedunculations are really shown very nicely by cardiac MRI. And so you can really characterize where you have fibrosis. Here's an example of hypertrophic cardiomyopathy and the fibrosis that's happening. And the reason that's important is that we're noticing that these patients who have late gadolinium enhancement have increased death, sudden death, cardiac mortality, and all-cause death. So really these patients who don't have it are doing much better than the patients who do have it. And so it's important when we see it also in tetralogy of Fallot like we did yesterday, and it showed predicted of clinical arrhythmias. And now we're seeing it also in Fontan. And there was a study out of Boston that looked at late gadolinium enhancement in late after Fontan operations. And it showed that there was a higher frequency of non-sustained VT in patients who had positive late gadolinium enhancement. So you see again, here's the EFE that I showed you earlier. Here's obvious coronary artery trauma that occurred to this left ventricle. There's also the heterogeneous, sort of patchy looking late gadolinium enhancement, as well as looks like an infarct along the wall of the ventricle. So in this cohort of late survivors, the myocardial fibrosis was common and associated with adverse ventricular mechanics and higher prevalence of non-sustained VT. This is going to put your patients at higher risk of dying. And so these are the patients that you would potentially work up earlier for transplant potentials, or patients that you would watch more closely. So we know the volumetric measurements by MRI are very good. How good are they for single ventricles? They seem to be much easier and to figure out, especially with ventricles that are not of the same bullet shape that we think about with the left ventricle. So patients that have this single right ventricle, or even a single left ventricle that doesn't have the right ventricle synchrony to help it, are going to help you. And here's an example. And when you look at the myocardial mass at diastole and end systole, they're almost exactly the same. You have less than a 5% error. And that really helps you in following these patients over a long period of time and looking to see if they're getting more and more dilated, to see if you need to start a new medication, watch what you're doing, and exercise tolerance for them. So I showed you this flow in the beginning. Here's another example of that. And in this one, you're looking to see specifically which blood is coming from the IVC and going to the right lung and the left lung. You can get a percentage of that from those patients and actually know exactly how much is going to each lung. In this case, you can see a little bit more is going to the right lung than the left lung. And why is that important? We know with patients who have hydrotaxy, they develop much more AVMs when less IVC flow is going to that lung, and you could potentially go in and redirect the flow and hopefully have the AVMs reverse. Dr. Fogel at CHOP has looked at that very closely, and here's the different anatomies of the Fontan, and then the percentage of flow that's going into each lung depending on from the IVC or SVC. And then now I wanted to show you some of the anatomy and really take a look at some of the examples of how the anatomy is beautifully seen in patients that are adults with different morphology. So this is a 28-year-old status post-Fontan with tricuspid atresia who's complaining of shortness of breath. And you can see a very dilated right atrium, almost kind of a smoke appearance in here. Not a well-working left ventricle. The ejection fraction is not good. And then when we did the twist and injected his, you can see there's a huge collateral that's taking up a good amount of the blood from the superior vena cava. You can see the collateral again all through here. And after the patient had this coil closed, his saturations came back up from 88% to 95% with improvement of his shortness of breath. Here's another patient, 39-year-old, status post classic Glenn and classic Fontan. And this is important. This was actually done by the techs that I work with, but an adult radiologist, or a radiologist that mostly does the adult cases, was going to read this out. You can see abnormal ventricular function, IVC, looks like there's a bit of stenosis there. But then more than anything else, the reason I got called is because they thought he had a pulmonary embolism to his left lung. And they called to see what I thought of it. And after I read the op note, I realized, well, he had classic Glenn and classic Fontan. The only way blood is going to show up in that left lung is if you put an IV in his leg and actually get blood through the IVC to get to see that. So after discussing this with the radiologist, the patient had already been off the table, so we didn't put him back on the table. He agreed to not send him to the CT scan for pulmonary embolism, and he instead went to the cath lab for his IVC, which was opened up, and he did much better. Here's a 12-year-old with an unbalanced AV canal, which was a right ventricular dominant and hypoplastic left heart. She was having worsening function. You can see the prolapse of the AV valve right here at the end. And the regurgitant fraction, you can see the RV function is not great. Here's the very small hypoplastic left ventricle, barely really doing much. She had quite a dilated neo-aorta. And you can kind of notice the small but atretic native aorta. I think it's kind of hard to see. But then if we look at the velocity-encoded image, again, here's the neo-aorta, the native aorta. And then when you look at it at velocity-encoded image, the native aorta is black and the neo-aorta is white, showing you reversal of flow down to the aorta via the junction. So we took a look at her by non-contrast MRA, and here's the small aorta completely closed and the neo-aorta. And so you have reversal of flow to your coronary arteries, which probably doesn't help. Here, the coronary arteries, you can see they're pretty small off the aorta. You can also look at her branch PAs. Here's the LPA, RPA. You can look at it again. Definitely showing you that. I think I have one more. So tricuspid atresia with pulmonary atresia, 7-year-old who underwent Fontan. You can see very dilated, very big ventricle. You can see how you would potentially think this is the septum, very similarly to what Dr. Sanders showed us as an example. And because of the AV valves, consider possibly going in and closing that, but it's really a single ventricle. She has poor function that's noted also with reversal of flow and very poor flow in the IVC. And her ventricle is really not functioning very well. You can see aortic insufficiency here. Short axis images show you really poor function and very small hypoplastic arteries. You can see again. So I'm going to stop here just for time, but if anyone's interested in seeing any more pictures of the anatomies, I'll be glad to show them to you.